The thigh, hip, groin, and pelvis, chronic or overuse injuries. Pelvis or femoral stress fractures. The mechanism of injury is insidious, which means it's hard to differentiate when this injury occurs. Femoral neck stress fracture is the most common. Typically, these stress fractures are due to repetitive stress, such as jogging, aerobic dance activities, or from other overuse or repetitive activities. Signs and symptoms of pelvic or femoral stress fracture include pain in the femoral triangle, which increases during activity and decreases with rest. Pain is described as throbbing, burning, and paresthesia, which means that there is numbness or tingling that may be described. Management includes referral to medical services for a potential MRI or bone scan to assess femoral stress fracture or pelvic stress fracture. Osteitis pubis, also known as pubic symphysitis. Osteitis pubis is an overuse injury characterized by tissue damage and inflammation of the pelvis at the site where the two pelvic bones join, known as the pubic symphysis. This results in groin pain. Osteitis pubis is usually an overuse injury which commonly occurs due to repetitive or prolonged activities placing strain on the pubic symphysis. This occurs during repetitive running, kicking, or change of direction activities. This is commonly seen in running sports such as football, hockey, and other athletic activity, including marathon runners. But it is also seen frequently in rodeo athletes from the amount of pressure on the legs to hold a cowboy or cowgirl onto a horse or bull. One of the main causes is instability of the pelvic bones, and in particular, the pubic symphysis. The instability is aggravated when asymmetrical loads are placed through the pelvis, such as when running or kicking. These activities are normally well accommodated in the normal stable athlete, but with poor lumbopelvic control, the additional forces are uncontrollable and can cause injury. Patients may also develop osteitis pubis during excessive abdominal contraction, such as during repetitive sit-ups or following inadequate rehabilitation of other injuries, such as an adductor tendinopathy. Patients with osteitis pubis typically experience groin pain that develops gradually over time. Pain may be experienced on one or both sides of the groin. Pain can sometimes also be experienced in the lower abdominals. Patients will complain of pain with firmly touching the pubic bone at the front of the pelvis. Pain may also increase when squeezing the legs together or when moving the affected leg away from the midline of the body. This is known as an abduction or abduction movement. Pain is usually aggravated by exercises such as running, kicking, or performing a sit-up or a change of direction activity. In less severe cases of osteitis pubis, patients may only experience an ache or a stiffness in the groin that increases upon rest following activity. As the condition progresses, patients may experience symptoms that increase during activity and affect performance. In severe cases, the patient may be unable to continue the activity and may even limp or waddle as a result of the pain. Management for osteitis pubis is price and NSAIDs. If the patient is not improving, it may be a good idea to send them to a physician to be evaluated further. Avascular necrosis of the femoral head is a pathological process that results from the interruption of blood supply to the bone. Avascular necrosis of the hip is poorly understood, but this process is the final common pathway of traumatic or non-traumatic factors that compromise the already precarious circulation of the femoral head. The femoral head ischemia results in the death of the marrow and osteocytes and usually results in the collapse of the necrotic segment. Avascular necrosis can either occur after a traumatic event or from a non-traumatic event. Traumatic avascular necrosis typically occurs following a significant hip injury, such as a dislocation. Non-traumatic avascular necrosis most frequently occurs after the patient has used specific medications, such as steroids, suffers from blood coagulation disorders, or uses alcohol excessively, among other secondary causes. Leg-calf perthys disease. Leg-calf perthys disease is avascular necrosis of the proximal femoral head resulting from compromise of the tenuous blood supply to this area. Without sufficient blood flow, the bone begins to die, and it breaks more easily and heals poorly. This disease has an insidious onset and may occur after injury to the hip. Risk factors for leg-calf perthys disease include age. Although leg-calf perthys disease can affect children of nearly any age, it is most commonly occurring between the ages of 3 and 8. The child's gender. Leg-calf perthys is up to 5 times more common in boys than girls. Race. Caucasian children are more likely to develop this disorder than are other races of children. And family history. In a small number of cases, leg-calf perthys appears to run in families, so there may be a genetic component. Signs and symptoms of leg-calf perthys disease include limping, pain or stiffness in the hip, groin, thigh, or knee, limited range of motion of the hip joint, and leg-calf perthys usually involves just one hip. Both hips may be affected in some children, but usually at differing times. The management for leg-calf perthys disease may either be surgery or a conservative treatment. To keep the ball part of the joint as round as possible, doctors may use a variety of treatments to keep it snug in the socket portion of the joint. The socket acts as a mold for a fractured femoral head as it heals, so a hip brace may be enough to limit the motion and allow the bone to heal, or surgical intervention may be necessary. A slipped capital femoral epiphysis. A slipped capital femoral epiphysis is an unusual disorder of the adolescent hip, although it is not particularly rare. For reasons that are not well understood, the ball at the upper end of the femur, or the thigh bone, slips off in a backward direction. This is due to weakness of the growth plate. Most often it develops during periods of accelerated growth or shortly after the onset of puberty. The cause of a slipped capital femoral epiphysis is unknown. However, it occurs 2 to 3 times more often in male children than in females. A large number of patients are overweight for their height. In most cases, slipping of the epiphysis is a slow and gradual process. However, it may occur suddenly and be associated with a minor fall or trauma. A symptomatic slipped capital femoral epiphysis that is treated well and early will allow for a good long-term hip function. The typical patient has a history of several weeks or months of hip and knee pain and an intermittent limp. In certain severe cases, the adolescent will be unable to bear any weight on the affected leg. The affected leg is usually turned outward in comparison to the normal leg, and the affected leg may also appear to be shorter. Management for a slipped capital femoral epiphysis is placing the patient on crutches to limit weight-bearing activity and referring the individual to a doctor. This condition may require surgery to correct. Trochanteric bursitis is an inflammation of the bursa, the fluid-filled sac near the joint, at the outer side or lateral point of the hip, known as the greater trochanter. When this bursa becomes irritated or inflamed, it causes pain in the hip. This is a common cause of hip pain. Trochanteric bursitis can result from one or more of the following events. Injury to the point of the hip. This can include falling onto the hip, bumping the hip into an object, or lying on one side of the body for an extended period of time. play, or work activities that cause overuse or injury to the joint areas. Such activities might include running upstairs, climbing, or standing for long periods of time. Incorrect posture. This condition can be caused by scoliosis, arthritis of the lumbar or lower spine, and other spinal problems. Stress on the soft tissue as a result of an abnormal or poorly positioned joint or bone. Some examples may be a leg length difference or arthritis within the joint that places stress on the soft tissues, and other diseases or conditions. These may include rheumatoid arthritis, gout, psoriasis, thyroid disease, or an unusual drug reaction. In rare cases, bursitis can be a result of an infection. Previous surgery around the hip or prosthetic implants in the hip can also aggravate this condition. Hip bone spurs or calcium deposits in the tendons that attach to the trochanter may be an aggravating source. Bursitis is more common in women and in the middle-aged or elderly people. The signs and symptoms of trochanteric bursitis include pain on the outside of the hip or thigh or even in the buttock, pain when lying on the affected side, pain when you press in or on the outside of the hip, pain that gets worse with activity such as getting up from a deep chair or getting out of a car, and pain when walking upstairs. There may be localized swelling that is palpable, and snapping hip syndrome may occur. The tendons from the hip musculature may snap over the trochanteric bursitis, causing the snapping hip syndrome. Management for trochanteric bursitis will include price, NSAIDs, deep friction massage and rest, and if the condition is not improving, referral to a medical provider. Finally, we have snapping hip syndrome. Snapping hip syndrome is from a chronic bursitis that can lead to snapping hip syndrome. This is a benign condition that's very prevalent in dancers, runners, and cheerleaders that may develop secondary to a variety of both intra-articular and extra-articular causes. There are 3 different types of this condition. One is external. This is the most prevalent and most common cause. This is caused by the movement of a thickened iliotibial band or IT band, tensor fascia lata or gluteus maximus tendon, snapping over the greater trochanter during hip flexion, which then leads to trochanteric bursitis. A second source is internal. This is a less common but more pronounced condition and is caused by the iliopsoas tendon snapping over the anterior hip capsule, the lesser trochanter, femoral head, or iliopectineal eminence. And finally, the third source is from lesions on the joint, such as a labral tear, that causes a recurrent hip subluxation, osteochondral fracture, or intra-articular loose bodies that can lead to the condition. Snapping hip syndrome is characterized by a snapping sensation rather than pain that is either heard or felt during certain motions of the hip. It usually occurs when a patient laterally rotates and flexes the hip joint while balancing on one leg. If the iliopsoas bursa is affected, the patient may complain of snapping, chronic pain, or both in the femoral triangle of the medial groin. The femoral triangle is shown in this image. Management for this condition is usually handled with limitation of hip motion, particularly limitation of extension by the use of an elastic wrap. Ice and NSAIDs are used to relieve inflammation and pain. If this is associated with pain or a sense of hip joint instability, then the patient should be referred to a physician. A rehabilitation program should address specific deficits, including stretching exercises for hip abduction and external rotation, muscle imbalances, poor training techniques, or poor biomechanical movements.